Feel free to start whenever you're ready, Dr. Dawson. Everything looks good.
Hey, great. Well, thank you, Tess, as always. And I have to say, I feel really privileged and lucky to have such wonderful friends and colleagues in both BRCA and BC and Inspire Health. And I love you all, and I love working with you all. And it's always great to come and talk about my favorite topics, which are in particular cancer prevention naturally and women's health and menopause. So very happy that I get to put all those things together today with this lovely group. So what we decided we would name this talk is Hot Flashes, Hormones, and More. But I'm not just going to talk about hormones and menopause. I do want to talk at a high level about ovarian cancer prevention and where we are in 2024. And I'll start out by saying I think that there's a lot of really cool things happening, a lot of new research coming, and I hope at the end of today people walk away feeling empowered, feeling hopeful, and with lots of resources and information that's useful for them. Oh, okay. Before I start talking, I just want to say that since I will have spoken to this group and others last time, we now at my clinic, which is the Gynecologic Cancer Prevention and Survivorship Program, we now have a website which is called gpscancerprogram.ca.org.com. So for anybody who's interested, by all means, have a look there. A lot of the things I will be talking about are going to be referenced in the vast amount of materials that we've listed on this website for people. Likewise, there is a research paper that was written happily by our team that's going to outline a lot of the things that I'm going to say today as well. And so for people that don't mind slogging through a more medical piece of reading, this is fairly accessible, and it's in the journal Cancers, published in January last year. And if anybody's having difficulty getting hold of it, let me know, and we can certainly circulate it for you. But this will go through exactly what we're going to talk about today, which is for those of us with BRCA mutations who are making these big decisions about ovarian cancer prevention, what are the other factors that need to be considered? And what are all the issues around the decision to have preventative surgery? And so with that, I'll just get cracking. So I'm going to talk to you about an overview of where we are with screening and prevention and the care of people with BRCA mutations, where the recommendations are today, talk briefly about surgery and some specifics about surgery, but the biggie, of course, is going to be post-surgery care. And if time permits, I do want to talk a little bit about some really exciting research that's happening, particularly in the domain of the evidence that some of these what we call ovarian cancers really start in the fallopian tube. But today, really, we're going to talk about care after surgery for the most part. I can't do this sort of talk and talk about ovarian cancer prevention without saying the thing that I hate to have to say, which is that if we look at the amazing amount of research that has been done on the question of whether or not we can screen for ovarian cancer, unfortunately, I wish I didn't have to say that, we do not have an effective screening test for ovarian cancer, either in the general population or yet proven in people who are high risk, for example, those people with BRCA mutations. And this little graph down on the bottom, you can see the curves with different colors, the lines. In any research study, if we're hoping to see a difference between two groups, we would see differences in the trajectory of those lines. And you can see clearly in this huge study with tens of thousands of people in it, that there was no difference in the people, their outcomes if they were having screening for ovarian cancer with ultrasound and blood work, or if they were not. So what I say in clinic, and for lots of you I think are in my clinic that are online, people can do these tests, but I cannot look you in the eye and tell you to take them to the bank or have any assurances that screening will detect an ovarian cancer at an early stage. Just in general terms, for this audience, we're talking about people with a high hereditary risk, but there are levels of ovarian cancer risk. The general population risk is about 1.3%, and there's various things that people can do in their life, or maybe their predisposition, that can change those risks. There's going to be people in the middle who have a family history, but no proven genetic mutation. And then, of course, for this audience, people with hereditary predispositions such as BRCA1 and 2 have substantially elevated risks that are, approaching 20-fold, 30-fold what we would see in the general population. So here we are, and you're a person who's learned that you have a BRCA mutation and you're trying to make some of these decisions. And what are all the factors? So we've talked about screening. What are the other things to think about? Should I have surgery? What are the downstream surgical complications? What about other effects of removing ovaries on my health, my brain, my bones, my heart? What about my quality of life? What about my sexual health? And these are the things I'm going to go through today. I can't, again, resist talking about in the terms of prevention before we get to surgery. It's really important that people know that ovarian cancer risk is substantially reduced, even in BRCA carriers, in people who take the birth control pill. And so we can talk about breast cancer risk another day, but I will say that even in people with BRCA who've taken the pill for more than 3 years, we do see a substantial reduction in ovarian risk. If you want more resources on genetics, there are a couple of really good things. The first is the National Comprehensive Cancer Network. This is freely available online. You do have to get a password, but it's there, and you're looking for genetic familial high risk. This is updated now. The one I'm showing is September last fall. The new one is just November this year. And there is also a really good practice guideline about the gynecologic management of people with high risk for hereditary breast ovarian cancer. And again, anybody wants their hands on these, we'll be happy to share them for you. So again, these are things you know, but what's important to know is that I'm talking today about graph B. Can people see my cursor, by the way? Yeah. So, we're looking at the risk of ovarian cancer in somebody with BRCA1, the risk of ovarian cancer in BRCA2 in your lifetime. If you have BRCA1, that lifetime risk is going to be approaching 40%, a little higher. BRCA2 approaching 20%. I usually quote about 17. And that, remember, is in contrast to that 1.3% we said before. While we're on screening, I just want to put a shout out for a study that is open now in British Columbia called the CHARM study, which is testing out a new blood test. If people are interested in joining this, they can look at the website called CHARM Consortium, and it's arranged through the Hereditary Cancer Program. If you reach out to the Hereditary Cancer Program, you can get more information about this study. There are some big studies happening now looking at those things like ultrasound and blood work in very high-risk people. We don't have any results yet, so I can't tell you much yet about screening. And here's the big thing. So this graph here on the bottom, you can see these triangles and squares, is what's called a forest plot. And in essence, if you look at the line that goes up and down in the middle of that graph, when we're looking at a bunch of studies and trying to figure out if things are favorable or negative, we're looking at where those shapes land on either side of that line. And what's important to see, this is the summary of all the studies looking at salpingo oophorectomy, or you'll hear me say RRSO. RRSO in people with BRCA mutation is associated with a substantial shift this way, which is really proving to us that this is not only a very, very effective intervention, which substantially decreases the risk of ovarian cancer. And that translates not only just to ovarian cancer risk, but for certain types of mutations, also to a decrease in breast cancer risk, so that across the board for a young, healthy BRCA carrier who has a surgery, the overall benefit in having this operation is a 70% improvement in all-cause mortality. And I will say there's not much in medicine that gives us that kind of substantial life-saving impact. So as much as I would love to say that surgery is not the right way, I have to say clearly that the evidence is very supportive that carrying on with surgery is, at this stage of the game, the right decision. The challenge, of course, is that based on the evidence, and if you remember that graph I showed you, when the ovarian cancer, the age at which those ovarian cancers start to happen, unfortunately, it does mean that people are considering having this surgery before they would have had their natural menopause. And that's what this talk is about today. And so the guidelines, and they're very clear, is that if you have a BRCA1 mutation, the recommended timing for you to consider removal of tubes and ovaries is between the ages of 35 and 40. Doesn't mean you need to run to the OR the day you're 35. You're going to tailor it around your life, but in that range. And likewise for BRCA2 between the ages of 40 and 45. I don't know if there's people online with some of the other hereditary breast ovarian cancer genes. Most of those are less common, but the age at which the cancers occur, and therefore the age at which surgery is recommended, is a little later. We have good Canadian data on this as well. And so in Canadian studies where they've looked at just BRCA1 carriers, thousands of people, looking at those people that tried to have screening versus those that have surgery, the hazard ratio, meaning the absolute difference in the two groups, is very, very substantial, suggesting that, again, this is a life-saving procedure. And therefore, all of the various medical organizations worldwide, our Canadian group of obstetrics and gynecology, the Gynecologic Oncologists of Canada, the American group, the British groups, the European groups, are all saying clearly, based on this very, very strong scientific evidence, that surgery at this stage of the game is the right way to go. So what are the factors? So we need to be practical. You know, this easy to read a research paper, but we need to look at for each individual person, they got to look at their life and what works for them. And in our clinic, we spend a lot of time talking to people about these factors. You know, have you had a breast cancer? Are you planning breast surgery? What are the personal circumstances? What are the age of your kids? Where should you have surgery? Do you need to be in a big center? Can you have it in the community? All those factors. What particularly should removal of the uterus or hysterectomy be included? So there's a lot of factors that need to be discussed. And that's why we would strongly encourage anybody who's thinking about surgery to come and talk to us. And we will help you work out those things for you that's personal and meaningful for you. In terms of the operation itself, the complication risks are very, very low, really low single digits. In large series of people, you know, you'll have a couple of people with major complications, very rare, 1 or 2%. The risk of a complication does increase a little bit if you are having hysterectomy along with that, or in people as you age, as you're heavier, you're older, or if your body mass index is higher. But on balance, this is done as an outpatient, and most people are home that day, and the complication rate is really low. Many people want to know, should they have their uterus removed at the time of the surgery? And I will say across the board, for the most part, I recommend no, because it does make the surgery more complicated. There will be some people for whom this is the right choice, and there are some pros and cons. There have been some papers that have talked about a risk of uterine cancer in BRCA1 carriers. I'm not sure we're all completely convinced by that research yet, and I don't routinely recommend it. It can, whether somebody has a uterus removed or not, does it influence a little bit the way we give their hormones? But on balance, it's not part of my routine recommendation. Oh, sorry. I do want people who have not had surgery to write down these words, SEEFIM, CFIM. And in essence, what that means is if you're going to the operating room, it's really important not only you know, that the tubes are removed, but that when the tubes are removed and they go to the pathology lab, that the team looking at the tubes under the microscope know that you have BRCA. And we know this is really important because very often the type of ovarian cancer that happens in people with BRCA is called high-grade serous. And very often those will start in the fallopian tube. And so we really want to make sure the pathologist, when they're looking through the microscope, does this serial extensive examination of the fimbria. And so what I tell all my ladies to do is to have a piece of paper and give it to the nurse, because the doctors may know, but depending who's filling out the forms, all those things, make sure that the nursing team, the whole surgical team, knows that you have BRCA and that CFIM protocol should be done on the pathology of your fallopian tubes. Okay, so let's just say you've come to all these decisions, you've made the choice to have surgery, you've worked out your timing, the pathology is going well, your surgery has gone well, what are the next steps? And so the average age of menopause in Canada is 51. And so for all of us, when we go through menopause, certainly I did, we feel it right away in the new onset of what we call vasomotor symptoms. For somebody who's having a surgical menopause, you're going to find that usually quite quickly. Most people will notice some hot flashes within the first day or so, a couple of days certainly. And what people, if we look at the studies, what people tell us is they have hot flashes. They may wake up in the middle of the night feeling hot and sweaty. Some people may find some changes in their mood. Some people may find some joint aches. And there's a long list of things that people will find when they have an acute menopause. What I'm here to tell you is that these are all things that we can help with, and that although naturally nobody would want to have a premature menopause because of surgery, that these are all symptoms that we can help you with and that we're very good at helping you with. And so, yes, quality of life after oophorectomy is a big worry for people, but that there's a lot of research and a lot of good interventions that can help you with those symptoms. Naturally, the first thing people are going to talk about is the role of hormone replacement therapy. And I will say, in medicine, we often use the term knowledge translation, meaning what happened in research gets translated into the community, into the public properly. And I will say hormone replacement therapy for the general population, people going through menopause naturally, and for people who've had a surgical or an early menopause, there's been a lot of misinformation about hormone replacement therapy out there. A lot of people have gotten incorrect messaging. There have been issues, certainly, with lack of training for healthcare professionals about hormones, so that many, even family physicians will tell me all the time, they didn't get enough training, so that they're not really feeling equipped to counsel their patients. And so I'm going to come to you now with what is the state-of-the-art recommendations about hormone replacement therapy. And I think, I hope to say at the end of this, a good news story. So naturally, for people that have BRCA, the first thing they're going to think about is, well, I heard that hormone replacement therapy increases your risk of breast cancer. I'm obviously worried about breast cancer already. I've been told, and many of you will have been told, you can never touch a hormone. And we have a lot of research on this, and there are many, many studies now that have taken big series of people who had their ovaries out, who have BRCA, who did not have mastectomy, and followed them and looked at those people that did take hormone after their oophorectomy and those that did not. And in none of those studies are we seeing a signal where there's an increased risk of breast cancer in the people that took their hormones. So I can't be clear enough about this, that if for a young, healthy person who's decided to have their tubes and ovaries removed with BRCA mutation, even if your breast cancer risk is elevated, once your ovaries are out, if it's a premature menopause, you can safely and should take hormone replacement. Now, the things that we are going to talk about now are some of the downsides of hormone replacement, downsides of early menopause in people who've not been given the opportunity to have hormone. And we know for all of us when we go through menopause, that when we go through menopause, our cardiovascular risks change. And so when we have menopause earlier at a younger age, there is an increased risk of cardiovascular disease. And that is manifested by changes in your lipids, changing in your fasting glucose, changes in blood pressure. And so this happens to us all, but if your menopause is earlier than average, it will happen a little earlier than average. And we have a lot of evidence on this. These are graphs looking at things like blood pressure, high lipids, diabetes, seeing that people who have a surgical young menopause do have higher rates of these things compared to those people that were premenopausal or had a natural menopause.
Go ahead and open your jam session.
Excuse me, doll. I'm on the phone. I'm on Zoom.
going to
I can't talk.
jam session.
Sorry, teenagers. And we do have a lot of evidence on this. We do know as well that if people are given hormone replacement, that we can mitigate a lot of those cardiovascular disease issues. And in the Nurses' Health study, for people that had a premature menopause and had their ovaries removed, if they were not given hormone, we do see those downstream increased cardiovascular risks. What about your bones? Well, so we know that bone strength and bone development is strongly linked to estrogen as well as weight-bearing exercise. And again, we know when we all go through menopause that there is an increased risk of thinning of the bones. And that again is shifted slightly if you have a premature menopause. Again, we know that hormone replacement therapy mitigates those things. I've made this slide just a picture of a brain without a lot of data, very particularly to say that, in fact, when it comes to things like long-term cognitive effects of premature menopause, there is a real lack of research. We have some evidence that people who have premature menopause without hormone would have a higher rate of Parkinson's. There's been a lot of data and a lot of discussion about whether there's a risk of dementia that's associated with premature menopause, but we don't really have quite good enough data yet, and we don't yet really have good enough information about where hormones fit in with that. So I'm going to now share some slides that are put together by one of our students who helped us with that paper I mentioned in the beginning, where she went through all of the evidence on this and what is the safety, what are the guidelines. And one of the things that we studied as our team is we looked at BRCA carriers and other young women who had their ovaries out and looked at prescription patterns. And one of the things that we saw is only about half of people were even given a prescription for hormone. And after a year or two, the vast majority of them were still not taking this. And so there's a real, again, knowledge translation issue where people we know would really benefit from having their hormones replaced are not getting it done. And I'll tell you some stats from our clinic if we have time. I've already showed you these data. So over and over again, we're seeing that for people with BRCA mutations who've had their ovaries out, they can, in fact, should take hormone replacement when they have their ovaries removed. So our recent review, again, high quality data that is safe and does not increase the risk of breast cancer. Now, let's get into the meat of it. For cardiovascular disease, again, our group have shown that we have higher rates of cardiovascular disease in women with BRCA mutations. If they take hormone, those things are mitigated. But what was interesting is that in many, many cases, people were not getting the appropriate workup they needed to manage other risk factors. And for those of you that are in my clinic, you'll know that we're checking your lipids, we're checking your fasting blood sugar, we're asking you to get your blood pressure checked. We're talking to you, as is Inspire Health, about exercise and lifestyle things, because we know that a healthy young person who's having a premature menopause really needs to be on top of those other risk factors. And likewise, bone health, again, we're seeing over and over that these lifestyle things, all the things that Inspire Health are telling us to do, really do make a substantial difference to bone health. So what I'm trying to say as I boil it down is that, yes, there are concerns about having a premature menopause because of oophorectomy, but that with the appropriate screening and management and appropriate use of hormones, that we can mitigate those risks. Again, mitigates adverse health effects, prevents bone mineral density loss, reduces the risk of cardiovascular disease, and decreases the risk of all-cause mortality. So therefore, hormone repair therapy is the gold standard for the relief and all of these various relief of menopausal symptoms, and all of these various groups and guidelines are now outlining this for us very clearly. Now we're going to talk, I'm happy to talk in more specific terms about how to manage symptoms. For people, when we get to the question and answer, I'm not going to be able to give somebody particular medical advice about their own case, but we can talk in general terms about, what agents are out there. I have put in some trade names and some brand names. Many, many things now have generic brand names. I don't have any preference for any particular products. So, for the most part, I'm happy to talk about any of them. The things that are important to remember is that any menopausal hormonal regimen is going to have at the mainstay of it an estrogen. Those estrogens can be done either orally or transdermally. The type of estrogen that is most associated with, or most close to what our body makes anyway, is going to be 17-beta estradiol. And you will hear people throw around the term bioidentical. It's probably a longer conversation, but 17-beta estradiol is what we would call a bioidentical. Whether or not something is compounded does not mean that it's bioidentical. What that means is what the actual hormone is. We in our clinic tend to favor transdermal, meaning patches or gels, over oral for the most part. I have lots of ladies who feel better on oral and like their pills, and I think that's quite fine. But for somebody who may have any extra risks of blood clots, the transdermal preparations seem to have a lower risk of blood clot than oral. That's probably less relevant for a healthy 40-year-old BRCA carrier, but certainly for those of us who are going to be taking hormone later into our 50s and 60s, I think transdermal is a better way to go. For somebody who has not had a hysterectomy, like I'm recommending, the traditional sort of more older used medication was a synthetic progestogen. Nowadays, really, I would say the most common agent that, and many of you will be on, is a medicine called micronized progesterone. Comes as trade names and generics. And the micronized progesterone is given as a pill. Most people take it going to bed at night because it does have that added advantage of helping with sleep. For some people, if they maybe have a peanut allergy and can't take the prometrium, or people for other reasons may decide not to have a systemic progesterone and may in fact have a Mirena, which is an IUD that secretes a little bit of progesterone in the uterus. There is a third class of medication on the market now. There's only one product, which instead of having a progesterone to balance the estrogen, has a different medicine called a beta-doxyphene, which is really a cousin of tamoxifen, if you will. And in that particular case, somebody taking that agent would not need a progesterone as well. We're really interested in this agent, and I'm not here to recommend anything yet, but I will say that, there is some evidence that maybe beta-doxyphene could decrease breast density, which we would feel would be quite promising in a high-risk population. We don't yet, I can't yet say that it is a preferred agent. I do have a lot of ladies that take it and find it quite works for them well. It's quite good if people are having any ongoing bleeding. It settles bleeding well. It doesn't have the benefit of the sleep with the progesterone, but if it decreases breast density, as the research maybe is pointing towards, it could be promising. So the point is there's a lot of products for what we call systemic hormone replacement to control things like hot flashes and sleep disturbance. Maybe, I don't know, probably I shouldn't pause now for questions. I'll wrap it up when we can circle back. For those people that have had a breast cancer, you're probably listening to me saying, well, hang on now, this is all very well and good, but you haven't talked to me about what I'm supposed to do because my medical oncologist has told me I can't take hormone replacement. And so I'll tell you the story of how we came to that final or that conclusion as of 2024. There were a few studies that have been done that not all of which got completed that were looking at the use of hormone replacement therapy in people who'd had a breast cancer. And once there were two trials, one was called a habit study, one was called the Stockholm study. And what happened is one of them started and they started to see a trend in the early data that maybe there was an increased risk of breast cancer, and the study was stopped. And because the first study was stopped, the second study was stopped. And that's where it landed. So as we have now had some years go by since those studies, people are now doing what's called a meta-analysis or, detailed reviews of those studies, trying to tease out, is there really a risk for people with breast cancer and can they take hormone afterwards? And again, I'm showing you this forest plot with the squares and diamonds. Remember last time when we talked about oophorectomy and the trend was so much in the positive direction. Unfortunately, for this top one, which is people who've had an estrogen sensitive breast cancer, it does appear, at least in this state, at this stage, that there could potentially be a trend toward increased risk of recurrence in people who've had an ER positive breast cancer. So that's where we sit right now. There's a lot of work being done on this, a lot of interest in how we can come up with other ways to manage menopause in people with breast cancer, and I do it every day in my practice. So we'll talk about that. For the people who've had a triple negative breast cancer, this is an evolving field. Increasingly, I am seeing some medical oncologists changing their view based on some of these research papers. And what you can see is the shapes in here are really around the line, meaning that they haven't really confirmed harm in people who've had a breast cancer that does not have receptors for estrogen or progesterone on it. So I do now increasingly in my practice have people who've had a triple negative breast cancer where we've given them hormone replacement. I always do it in consultation with their breast cancer doctor. And so it's on a case-by-case basis based on the age of the person, their symptoms, the specifics of their breast cancer, and we do it as a shared decision-making team decision. For those of us that are not going to be able to take hormone, there are lots of other agents and lots of other interventions that are highly effective. For people that want to really get into the nitty-gritties of it, the NAMS, which is called the North American Menopause Society, is the American group. They have come up with a very thick guideline on all of the research about all of the non-hormonal agents. And they've come up with what they feel are the things that have got the most evidence behind them. Now, that's not to say that some of the other things that didn't make the cut aren't good. It's just that they maybe didn't have the type of studies executed that were sufficiently strong to make the cut. In terms of medications, in my practice, I use a lot of venlafaxine. Some people might know it as the old-fashioned trade name Effexor, which can be associated with a 70% improvement in hot flashes. A medicine called gabapentin that some people might have used if they had chemotherapy and had any neuropathic pain. Also, people with any diabetic neuropathy or MS neuropathy. Gabapentin is quite effective at decreasing hot flashes, particularly at night, and it can be quite good if sleep is the thing that's bothering you the most. And there is now a new class of medicine that are being developed or are developed and have a Food and Drug Association approval in the US and in Europe. And my understanding is it's on the desk of Health Canada now. And those are going to be neurokinin B antagonists. And these were developed very specifically for hot flashes. And they work at the area in the hypothalamus where the thermostat is, to target the place that's triggering this vasomotor instability or issues with heat intolerance. So these are coming very soon. And for people in our practice who've had a breast cancer, you've heard me talk about them before. The minute we know when we're going to have access to them, we'll be happy to learn more. I don't know trade name. I don't know where the price point is going to land yet. And that's how these work. They work right at the level of the hypothalamus and are quite effective at decreasing hot flashes. The other medicine that is on the market, many of these were developed for something else and had the happy side effect of being good at hot flashes. And another one is a medicine called oxybutynin, which was developed for people with overactive bladder. And we use this too, and it works really well. So my point, I think, is to say that if you are somebody for whatever reason who cannot take hormone replacement, we have lots of other options out there. I happen to think that acupuncture can be very effective. Certainly yoga is very effective. And one non-medication intervention that works very well is cognitive behavioral therapy. So we have lots for you there, and don't feel that you need to put up with sleep deprivation and really bad hot flashes if you can't take hormone. We got lots of other things. And then the last thing I'm going to say, just watching time, last thing I want to talk about is what's called genitourinary syndrome of menopause. And this cartoon here on the side is a picture of a vagina. And so it shows what a healthy vagina would look like and what happens as we age. And for all of us, when we go through menopause, the bladder, vagina, and the vulva have a lot of receptors for estrogen. And so those tissues get thinner and can get frailer and can cause symptoms over time in the absence of estrogen. And so how does that show up in our bodies? It shows up with that feeling of feeling dry. For some people, it may translate to irritation in the bladder, peeing more often. Down the line can be bladder infections. And for many people, what they'll notice is they're having difficulty with lubrication or pain with sex. The thing that's really, really good to know with this is that this is an absolutely preventable problem, and that the amount of estrogen that it takes to reverse this is very, very small. And so we have very good research that people, even with a triple negative breast cancer, can safely take just the little amount of hormone that it would take to prevent genitourinary syndrome of menopause or reverse it. So this is a very good news story for anybody. And for people that are having difficulty, it works, and it works really well. It takes a few months sometimes. There are a lot of products on the market. Traditionally, it's been creams. Most of the creams you would start using every day for 2 weeks and then go to twice a week. There are also, some people don't like the cream, they find it messy. Some people like the inserts, and there are several inserts on the market that are not nearly so messy, but may not give you symptoms if you're dry on the vulva. There is a ring as well. It's been hard to get on the market. There's been some supply chain issues with it lately that you put in and you change every 3 months. So there's a ton of formulations that work really, really well. So for people that are having these vulvovaginal bladder symptoms, you do not need to be struggling with these. One word about the trip to the pharmacy for somebody who's had a breast cancer when they're getting their vaginal estrogen. The rules of pharmacies and Health Canada are that you insert the labeling for the medication regardless of the dose, regardless of the absorption. So for somebody who's got a triple negative breast cancer and they've been told they can't have estrogen, if they go and get their Premarin cream or their Vagifem or whatever their product is going to be, they're going to get that estrogen insert. All of the various menopause societies, OBGYN groups, et cetera, have been advocating that this so-called black box warning does not need to be on vaginal products. If we measure the blood levels of somebody using these vaginal products, we do not see a spike of estrogen outside of a postmenopausal range. Having said that, you're still going to get the insert, that we've not been successfully able to take away those warnings for people. So I always say to people, don't worry about that when you get it. This is a labeling thing. This is not because there's a danger to you with a low dose vaginal estrogen. So I've already said about the cardiac disease. I've also already said about the bone disease. In our research within our team, what we've seen is that people, like I said earlier, were not getting these screening interventions to prevent the long-term effects. So for example, we were seeing that people weren't getting their lipids checked. They weren't getting their diabetes screen. They weren't getting a bone density done. And you will know from our clinic that we now routinely check all those things. So for somebody that's had a premature menopause, make sure that you do not have any other risk factors that you could be on top of. Make sure that we're managing any other things as well as giving you hormones if it's appropriate. This is just a little ad for our clinic. We have lots of partners, again, NSGPS cancer program. And the last thing, do I have time to talk about self-injectomy? It's about 3 minutes. Thumbs up, Tess, thank you. So I've thrown all this information at you, and people I'm sure are saying, well, wait a second, I really am not crazy about this idea of a premature menopause. Wait a minute, you told me that these cancers start in the fallopian tube. Why can't I just take out my tubes? And boy, do I wish I had an answer for you on that question today. We do not. What we know is that this little schema seems to be the way that cancers in BRCA carriers start, which is they start with little molecular changes in the fallopian tube that become a cellular change that eventually become a cancer. And so it makes a lot of sense that if these cancers really start in the fallopian tube, maybe just removing the tube will be enough. Obviously, we can't just make that jump without the research behind it. And this is research that's going to take a long time for us to know for sure, is it safe to take out tubes only? So it is not standard of care. And I would not want anybody to hear me talking today and go away and say, well, look, you said these start in the tube. I can take my tubes out and I don't need to complete the oophorectomy. That is incorrect. The standard of care, if you have BRCA1, is for risk-reducing salpingo oophorectomy between the ages of 35 and 40. The standard of care, if you're BRCA2, is between 40 and 45. And I wouldn't want anybody at this stage to go outside of those recommendations because that's where the safety sits. So where are we with the research? So we know that in the general population, so people without BRCA, if they have their tubes out, let's just say at the time of a hysterectomy for another cause, it's starting to look in the research that's been done by our team that the risk of high-grade serous cancer is reduced. So that's promising. But BRCA carriers are not the general population. The risks are higher, and we need to be a lot more careful about these high risks of ovarian. So we don't yet know, but in the general population, it's starting to look promising. Dr. Kwan, my partner in the clinic, has published on this and looked at very complex modeling of what would happen. Could we do it this way? Maybe you could have your tubes removed at a younger age and then bump the oophorectomy later. And I will say, I still stick within the lines of those guidelines, those age ranges that I've talked about in my practice, but I do increasingly see people who might decide to have their fallopian tubes removed at 35 if they're not using them, and then have their ovaries closer to 40 with BRCA1. So we're starting to see people make some of these changes, but again, I don't want them to go outside of the guidelines. How are we going to know that it's safe, and how are we going to figure that out? Well, so this is one of the things I was really excited about giving this talk today, is because I can tell you that there are 3 big trials in the world. One is called the Protector study. It's in the UK. I know that team very well. I work closely with them, and they are following people with people are joining this Protector study. They're going into surgery. They're deciding themselves if they want to have their tubes and ovaries out or the tubes only and then ovaries later. And we're following people over time to see what the safety data looks like. That's the UK trial. The other 2 studies, one is coming out of the Netherlands and one is coming out of the US. We are now opening in British Columbia. And I think we're probably one of the only centers that's going to have both. So this is a fantastic opportunity for anybody who's listening who has not yet planned surgery to get a chance to get in on really important research. Where not only could you potentially benefit, we don't know, but you certainly will benefit those who come behind you in terms of getting the answer to this question. The SOROC study, which is the US one, the bottom one, the website for it is here on the bottom, is for BRCA1 carriers only. The top one, Tuba-Wisp, out of the Netherlands, is for all BRCA carriers. SOROC we have open now, and I guess I'm going to say we have maybe a dozen plus patients on it. And Tuba-Wisp is going to be soon. We're not quite ready to open, but it'll come soon. So please, 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 if you're interested in research, reach out to us. What happens with the studies is you're not randomized, the person chooses. But your tubes will get a lot of extra attention. And the protocols are done very, very carefully. You're followed for a long time. The only, I would say, perhaps downside is that if you are going to join one of those trials, you do have to have your surgery in Vancouver. So if you live outside the Lower Mainland, there's the factor of travel. But barring that, these are really great opportunities to be in on really big research. And is salpingectomy safe? We have good evidence in the general population that people who have their tubes out, really the complication rate is extremely low. And does it work? Well, stay tuned. We'll see what the studies show. And I want to wrap up by telling you, some of you have seen me show this slide before. This is one of my all-time favorite patients named Emma. And Emma is the only person I've ever known who ordered a pizza to the chemotherapy unit. And she was in Newfoundland, we would say a hard case. And Emma was part of a huge family. When I met her, we didn't really understand much about BRCA or ovarian cancer. I would have met her for the first time in 2001. And as we grew together with all of her, treatment that she needed for ovarian cancer, she had more and more breast and ovarian cancers in her family. And eventually we were able to figure out that, in fact, she had a BRCA2 mutation. What's really lovely that she would be proud that I'm showing this slide is this is a schema of her family. And you can see in the top, those little people that are colored in and with dark colors, those are people that had cancers. If you look in this big, vast family now across, all you can see is everybody is white. There's no dark, no black in all those colors, meaning to say that we now have two generations. I've met her great-granddaughter who are not getting cancer, and they're not getting cancers because they have availed of this life-saving prevention. And on behalf of Emma, let me tell you, this is at this stage a really hopeful time in BRCA care. So it's not one size all. Please let us help you. Ovarian Cancer Canada is here to help. Inspire Health is here. BRCA and BC is here. Our clinic is here. You're not alone.